All right, so we're going to continue with our discussion of cardiac MRI. In this lecture, we'll talk about, or in the next few lectures, we'll talk about imaging techniques, some specialized imaging planes, and then some other pulse sequences that you need to be familiar with for cardiac MRI. So these are going to be difficult but understandable concepts. The bottom line is you will need to review the lectures on your own slowly, since there's a lot of information we're going to be going through, and I don't expect you to understand this on the fly the first time. But the lectures will be available to you, and feel free to contact me if you have questions as you review the material. So there are two basic techniques for cardiac MR imaging that we can divide them into, or the two basic types of imaging sequences. We can divide them into black blood techniques, and our basic black blood technique is a double inversion recovery fast spin echo. That is a breath hold technique. And then we have white blood techniques. So black blood, the blood is black, so that's understandable. And then white blood techniques, the blood pool here is white. And then these bright blood techniques, we'll talk about some of these too, but these are used for evaluation of cardiac function and wall motion. These are the ones that give you movies, right? So the black blood imaging usually gives you a still picture, and then the white blood imaging gives you these movies that you can look at. So the problem with MRI is you're dealing with motion, and there are two types of motion. There's respiratory motion and there's cardiac motion. For the respiratory motion, we usually ask the patient to hold their breath during the imaging so we don't get breathing artifact during the sequence. But the other problem is cardiac motion. And in order to freeze the hard motion, then we need to use cardiac gating. So cardiac gating is a necessity to obtain a good MR scan. So the first thing you always have to do when you're doing an MRI study is to check the cardiac gating and make sure that your cardiac gating is good. So for cardiac gating, the software goes by the R waves here. So it uses these R waves to determine the cardiac cycle, the length of each individual cardiac cycle. So we have ECG leads that are placed on the patient, and so these need to be placed to identify the tallest R waves with the least amount of background noise. Now, initially, when you put leads on a patient, that's pretty easy to do, but things get complicated once you put the patient inside an MRI scanner. So outside of the MRI scanner, if you put leads on the patient and they have a regular rhythm, so the R waves are pretty easy to identify. But once you place the patient inside of the magnet, there's something called the magnetohydrodynamic effect, and this has to do with the moving blood containing ions in the magnetic field, and that produces voltages in and of itself that can kind of interfere with the recording that you're trying to get to identify the R waves. So when you place the patient inside the magnet, you get a much more complex ECG tracing here, where it can be harder to identify the R waves from the background noise. And so to deal with this, we use vector gating. And with vector gating, you'll see that the leads are set up a little bit differently than you would usually set up the leads if you're doing a normal ECG. And the way the vector gating works is that the QRS loop, the spatial changes in the voltages, are predictable over time. They follow a certain direction in three-dimensional space over time, as opposed to the MHE effect, which doesn't follow that direction. So the software is able to then separate out the voltage changes from the cardiac activity from the background having to do with the MHE effect. And this is from setting up the leads and using this what we call vector gating, so that the triggering will follow the true QRS loop for the patient. If all else fails, and for whatever reason that you're completely unable to get a good ECG tracing, the last resort is peripheral pulse gating. And what's done here is that we put this peripheral pulse monitor on the finger, and it identifies the peripheral pulse. And so the software then can use that to trigger or to gate off of. The problem here is that there's a long and unpredictable delay between the cardiac contraction and the arrival of the pulse. So you see I've put them both together here. And so this can introduce all kinds of artifacts in your imaging. So this is to be used as a last resort if you absolutely can't establish good cardiac gating on the patient. So everything starts with good cardiac gating. Now, optimally, your triggering signal should be very easily identifiable. So your QRS or your R wave should be very easily identifiable. But there is going to be all kinds of background noise. And so what you want to make sure is that as you examine the tracing on the monitor when the patient is inside the magnet, that the R waves stand out nicely against any background noise. So the software can identify the R waves pretty clearly. So that's very important. Now, one parameter that you can also set is a threshold, so that any particular voltage above that threshold, the software will interpret as the R wave. And if the threshold is set too low, then P waves or background noise can be interpreted as R waves. And in this case, it artificially makes the heart rate twice what it really is. So you want to make sure that before you even start the study, once you've set up the gating, that the R waves are easily identifiable, that your threshold is properly set, so that anything above the threshold really truly represents an R wave. Okay, so getting back to our basic techniques, with black blood imaging, this suppresses the signal from flowing blood, so the blood will look black. This gives you good spatial resolution. This is good for anatomy. And it gives you these still pictures. For bright blood technique, the spatial resolution is not quite as good, but this provides better temporal resolution. This is why we're able to look at cardiac motion here, and we will use these to evaluate cardiac function. And you get movies. That's what enables you to evaluate the cardiac function and to derive functional parameters from your imaging. So with the black blood techniques, we're only looking at one cardiac phase. We're just getting one image, and that one image is at a particular phase in the cardiac cycle. It may be out in diastole, but it is in one particular phase of the cardiac cycle, even though the information is acquired over multiple heartbeats. So it may take a 12 to 16 second breath hold, and the information will be acquired over multiple heartbeats, and then you will get images at this one cardiac cycle for every location in space, every axial image. As opposed to your bright blood imaging, where what we're really looking at is the entire cardiac cycle, and these are really still images throughout the cardiac cycle that are put together to give you this movie. So getting back to some basics, we talked about the spin echo sequence, 90-degree pulse, and then the 180 refocusing pulse, and then that allows you to get rid of magnetic inhomogeneity, and everything gets back in phase over there, and then that generates your signal. And so we looked at what your basic pulse sequence is for a basic spin echo sequence. We have a 90-degree pulse, we have a 180-degree pulse, and then we get signal out here. And then we talked about the phase encoding gradient and why we need to go through that. The read gradient is the frequency encoding gradient, and this has a dephasing and a rephasing lobe, and you have to make sure that this lobe matches up with where you expect the signal to be here, where the echo to be from your refocusing 180-degree pulse. So that has to match up. And so I won't go through this in any detail, but when you're going through these gradients, these will have dephasing and rephasing lobes. So whenever you apply a gradient, let's say a slice selection gradient, so that your 90-degree pulse only excites one particular slice, after you excite that slice, you have to sort of undo the damage of the gradient that you've introduced. And so that is the rephasing lobe of these gradients. So these gradients usually have a dephasing and a rephasing lobe, so that to undo the dephasing that is produced by the gradient itself. So when we're doing a spin echo sequence, when we're doing bright blood imaging and we're doing it with cardiac gating, we talked about what TR represents. TR is the distance between your excitation pulse. So when you're doing cardiac gating, what determines the TR for your scan if you're doing a black blood sequence? The heart rate. The heart rate itself. So the TR will be set to the heart rate, okay? So that your excitation pulses, the intervals between the excitation pulses are set to the heart rate itself, so that you're able to generate this signal here for each heartbeat separately, okay? So then the TR, the distance between the excitation pulses, will be set by the heart rate, okay? So that sets the cardiac gating for your spin echo sequences. Now, if we're doing a traditional spin echo sequence, right, we talked about if you have 256 pixels along the phase encoding axis, you need 256 echoes before you've generated enough data, before you've acquired enough data to fill K-space to have enough to generate an image, right? So if the heart rate is 60 beats per minute, so that means it's once per second, and we need 256 echoes, right? The TR is going to be what? What's the TR going to be?
60?
No, 1 second. The TR is going to be 1 second, right? So if your TR is 1 second and you're doing a traditional spin echo sequence, meaning you're only acquiring one line of K-space for every TR that you're doing, right? And you need 256 lines of K-space, how many seconds is that going to take? 256 seconds, right? And we said that we need a breath hold, right? We need to undo, we don't want respiratory motion in our scan. Well, nobody can hold their breath for 4 minutes to be able to do that, right? So we have to have ways of speeding up the imaging if we're going to do spin echo imaging to be able to acquire enough information within the time that we have that we can allot the patient for one breath hold. So if you're doing a traditional spin echo sequence, right, that's going to take 256 seconds if all you're doing is acquiring one line of K-space at every TR, and that's just way too long. So what can we do to decrease the imaging time? What can we do to speed up the imaging process? And this is what we're going to talk about. So filling up K-space takes time because we have to obtain a separate echo for each phase encoding step, right? So it's all of the phase encoding steps that we have to go through that takes up the time to fill up K-space. And if you have, like we said, 256 pixels in the phase encoding axis, that's going to require 256 phase encoding steps. So how can we speed up that process? Well, one way of doing that is by changing the sequence to what is called fast spin echo. And with fast spin echo, the idea here is that instead of acquiring one line of K-space after every excitation pulse, we acquire multiple lines of K-space after each excitation pulse. And what that means, though, is that you have to change the phase encoding gradient multiple times between the excitation pulses, right? So we're going to have to apply these 180-degree pulses each time, and then we also have to change the phase encoding gradient each time. And then every time we do this, between the 90-degree pulses, we're going to generate an echo here. But each time we generate the echo just before that, we're changing the phase encoding gradient. And each time we're changing the phase encoding gradient, each echo then allows us to obtain a different line of K-space. So in this example, instead of getting just one line of K-space here, 1, 2, 3, 4, you're able to acquire 4 lines of K-space between your 90-degree pulses. And that allows you to speed up the imaging process, okay? So your conventional spin echo sequence, 90-degree pulse, 180-degree pulse, echo, one line of K-space. Then 90-degree pulse, 180-degree pulse, echo. So here you're getting one line of K-space for every 90-degree excitation pulse, as opposed to fast spin echo, where we have our excitation pulses that are spread apart, and if we have 60 beats per minute, your excitation pulses will be 1 second apart, right? Your TR is going to be 1 second apart. But as we're going through this, so we apply the 90-degree, but then 180-degree phase encoding gradient echo, 180-degree phase encoding and gradient echo, 180-degree phase encoding gradient echo. So you see, now we're obtaining multiple lines of K-space between our 90-degree pulses. And this allows us to fill up K-space faster, to acquire the data faster. So the echo train length, that term echo train length, means the number of echoes between your 90-degree pulses. And so the longer your echo train length, the more echoes you're getting between your 90-degree pulses, right? The more phase encoding steps you've introduced there, the faster you're filling up K-space. So if your TR is 1 second, and if your echo train length is 16, meaning that we're going to fill up 16 lines of K-space every second between our TR pulses, then you've reduced your imaging time. It's just if you have 256 pixels along your phase encoding axis, you've decreased that by a factor of 16. So now, instead of 256 seconds, it only requires 16 seconds, which the patient can do. The patient can hold their breath for 16 seconds. So this allows you then to do a fast spin echo sequence, to do dark blood imaging in the allotted time, in the amount of time that you only have for one breath hold. Now, in the diagram that I'm showing you here, you see that the yellow signal, this echo, is the strongest. Theoretically, after a 90-degree pulse, shouldn't the signals get weaker, right? And that also fits into the second question that I have for you. What determines the TE for a fast spin echo sequence? Look, here we have multiple TEs, right? 1, 2, 3, 4, 5, at least 5 in this example here. There are 5 TEs here, right? But when you look at your image, when you look at a fast spin echo image, your TR, we know what that is. That's going to be what?
1 second.
The heart rate, right? In this case, it's 1 second. But the image itself has a TE on it. There's a number on there that says what the TE is. But there are multiple TEs here, right? So what determines the TE then for your fast spin echo sequence? Which one of these is the TE? The strongest signal, right. And what determines the strongest signal? What about the phase encoding gradient? And what is the lowest phase encoding gradient you can use? What's the lowest? It's not a hard question. 0, right? So the term we use is effective TE. So the effective TE is the TE with the lowest phase encoding gradient. Usually that's 0, right? So remember, we talked about the center of K-space that contains what? What does the center of K-space determine? Contrast, the image contrast, right? So your lowest phase encoding gradient determines your image contrast, and your lowest phase encoding gradient is 0. So the effective TE for any fast spin echo sequence is where the TE is set to 0. And so that's how you can change the TE. If I wanted this to be the TE, then, if I wanted this echo here to be my effective TE, I would make sure that the phase encoding gradient before that was set to 0. The lowest phase encoding gradient is going to give you the highest signal. The highest signal you'll get overall, over all of them, will be the one with the 0 phase encoding gradient. That's how you determine the effective TE. So when you get that number TE on the sequence that you're looking at, that's what that means, even though there are multiple TEs here that you're using to acquire your data, okay? So the highest signal is in the center of K-space, and that determines the image contrast. So the lowest TE, 0, will determine most of the image contrast. Okay. All right. So the term we use for this black blood imaging, double inversion recovery fast spin echo, we'll talk about what all that means in a minute. So it's a breath hold fast spin echo technique. The idea is to suppress the signal from flowing blood, and so the blood looks black. That's why we call it black blood or dark blood imaging. It gives you good contrast between the myocardium and the blood pool, and this is our optimal black blood imaging technique, right? Double inversion fast spin echo. All right, so what does this mean? Now we need to talk about a little bit about what inversion recovery means. If we give a 180-degree pulse, remember we start with longitudinal magnetization. If we give a 180-degree pulse and we allow time, right, this starts to recover here, right? But at some point, as it's recovering, at some point it goes through this zero line. That longitudinal magnetization starts out negative, but at some point it goes through this zero line right here, right? If you were to do an imaging sequence right here at this time, how much signal would you get from this tissue? What? None. Because you need, if you give a 90-degree pulse or whatever excitation pulse you need, you're going to provide, you need some longitudinal magnetization for that pulse to flip into the transverse plane. If there is no longitudinal magnetization, right, then you're not going to get signal from it. And that's suppressing the signal from this particular tissue. That's called the null point. All right, so you give a 180-degree pulse. The interval of time between here and here is the null point. If after your 180-degree pulse, you start an imaging sequence at the null point, you will then null the signal from that tissue. You will not get signal from that tissue. What's the point of that? Why do we want no signal from tissue? I thought the idea was the opposite, right? Well, what if you have two different tissues with two different null points? Okay. So you have this tissue here in red. You have this tissue here in green. Which tissue here has the shorter T1? The red one. It's recovering the longitudinal magnetization faster, right? So it has to have the shorter T1. So if we give a 180-degree pulse and invert both tissues, and then we wait until we get to the null point here of the green tissue, right? The red tissue has recovered longitudinal magnetization. So if we give a 90-degree pulse here, we will get signal from the red tissue, but we will not get signal from the green tissue. So we have suppressed this tissue that's annotated here in green by starting our imaging sequence at the null point of that tissue. Right? So that's how we can selectively suppress the signal from certain tissue and bring out other tissues. So it turns out that blood, if you think of it as the green tissue here, has a longer T1 than myocardium, as the red tissue. So part of what we want to do is we want to be able to start our imaging sequence at the null point of blood, using the inversion time, using the inversion time for blood, or the null point of blood. If we start an imaging sequence here, then we will suppress the signal from blood, and we will have signal from the myocardium, which is exactly what we want to do. Now, how are we going to do that? There's a fancy way of doing it called using this technique of dual inversion recovery. What does that mean? Well, first, remember, everything starts out as longitudinal magnetization. The first thing you do is we give a 180-degree inversion pulse to the entire volume, and it inverts everything 180 degrees. So you see whether this is the blood vessel here or the heart, the blood pool with the blood in it, that's the black. And in the myocardium, you can think of that as the white stuff outside of it. So we give a 180-degree pulse that flips everything 180 degrees, okay? And then we give a second 180-degree pulse that is slice selective, that is only for the imaging slice that we want. Okay, so what have we accomplished here? Well, for the imaging slice that we want, everything is back to longitudinal. This longitudinal magnetization is back where you want it. If you're going to give an excitation pulse, now we will get signal from here. But the trick is you wait just long enough here after this second pulse, the blood outside still remains inverted. You wait just long enough for that, for the inversion time, for the null point of that blood, which will then flow into your imaging slice during that time. So this inverted blood goes into your imaging slice, but before we start our sequence, we wait until the null point right here. And so now when we start our imaging sequence, the blood in the imaging slice will be suppressed, and we only get signal from the myocardium imaging slice. So you might have to go through this a few times to understand that, but that is the principle behind this dual inversion recovery black blood imaging that results in signal from the myocardium while suppressing the signal from blood that is flowing into the imaging slice. Okay? So what's the bottom line? This is a breath hold fast spin echo technique. It suppresses the signal from the flowing blood, and then that blood goes, into your imaging slice, and it provides very good contrast between the myocardium and the blood pool. Okay? And so here's a series of images. What plane is this? Short axis. You can read, right? Okay. That's the short axis plane. Now, what are other ways to speed up the imaging process? This is always the challenge in MR because remember, you need to acquire data from enough phase encoding steps to generate your image. So what are some other things you can do? We'll talk about some of these: rectangular field of view, this term half Fourier imaging, and then parallel imaging, which we also use a lot here. So what do these mean? So rectangular versus square field of view, we kind of talked about this, right? So if you have the option and you happen to have a rectangular anatomy, then it would be advantageous to place the phase encoding axis along the shorter diameter, right? Because then you have less phase and less pixels that you have to obtain information for along this axis of the patient. So it would require less phase encoding steps. Less phase encoding steps means shorter imaging time, all right? So that's the advantage of a rectangular versus a square field of view. This principle of half Fourier imaging, what does this mean? It turns out that, so this is a picture of what K-space looks like. Remember, to convert K-space to the actual image, what do you have to do to it? Fourier transform, right? But the actual picture of what K-space looks like, the raw data of what you've collected, looks like this. There is a symmetry to this. This has a symmetry that if you obtain a little bit more than half of this data, you can derive a close enough approximation to what the other half should look like because of there's a symmetry here in K-space, okay? So because K-space is symmetric, if we acquire only about 65% of our phase encoding steps, we can kind of estimate what the rest of this would look like and fill it in. And then that's enough to generate an image, okay? The penalty for that is it's not exactly the same as if you had actually acquired it. So your penalty is going to be signal to noise. There's going to be reduced signal to noise. But it does speed up the imaging process, all right? And that's called, these are the terms for it, half Fourier imaging, half NEX, half scan, and that's taking advantage of the symmetry within the data, the symmetry of K-space data, okay? So which axis is the phase encoding axis? And there's an artifact on this image, and how do you fix the artifact? So first question is, you have two axes here, right? So here is the vertical axis A, here is the horizontal axis B. Which one is the phase encoding axis, and how do you know? So why is B the phase encoding axis? Yeah, so you have wrap artifact here, where you have anatomy that has been mapped to the wrong place. This anatomy is supposed to be on this side, but in the image, it has been mapped to the wrong side. All right, that is called wraparound artifact, and that only occurs along the phase encoding axis. So how do you fix the artifact? How do you get rid of this? What do you do? What do you tell the technologist to do? Increase the field of view, right? So phase wrap artifact occurs from undersampling in the phase encoding direction. So to get rid of it, you have to increase the field of view, okay? So it occurs when the object is larger than the field of view along the phase encoding axis, and what will happen is data will be mismapped. Instead of appearing on this side of the image, it has been moved to the other side of the image, right? So here I'm proving it to you. I've just taken it and cut and pasted it to the other side. So you see that really this came from here, okay? That's wraparound artifact. That's from undersampling in the phase encoding axis. And what we have to do is, if that occurs and you want to get rid of it, you have to increase the field of view. Now, in many cases, we don't mind this, especially since we're looking at the heart and it is really off of the critical anatomy, right? So if your phase wrap artifact is off of the critical anatomy, it's okay. But if it's superimposed on the heart, now you've got a problem. And so how are you going to fix it? You have to increase your field of view, right? Now, why does this occur? It occurs because the object, don't worry about the math, but it occurs because the object is larger than the field of view along the phase encoding axis. So it means that there's been undersampling along the phase encoding axis. Whenever there is undersampling in the phase encoding axis, you will get wraparound artifact. You will get anatomy that is mapped to the wrong part of the image, okay? This usually doesn't occur along the frequency encoding axis because that is routinely oversampled. There is no penalty for oversampling the frequency encoding axis in terms of time, right? But if I didn't change resolution or anything, if I said I wanted now, don't change anything, just increase the number of pixels to sample all of this anatomy that was originally outside my field of view, if I tried to do it by increasing the number of pixels here, I would pay the penalty of increased imaging time, right? So that's why there's usually a limit to what you're doing along the phase encoding axis. So what happens is anatomy that is outside of, when you have set the number of pixels, or you set your phase encoding gradients and number of pixels, you're in essence telling the software the anatomy is in this region, right? And the software doesn't understand that any signal coming from outside that region is really outside. It will map it into the region, but it will map it into the wrong place, okay? All right, now what is parallel imaging? This is another way of speeding up imaging. And what parallel imaging is, again, whenever we're speeding up imaging, we're going to try to do this by cheating K-space, by acquiring fewer lines of K-space. So what parallel imaging is that you skip alternate lines, right? So you skip these lines in between. We skip alternate lines of K-space. But I told you that the penalty for undersampling K-space is what? What's the penalty for undersampling K-space? That's one, right? One is that signal to noise, absolutely, right? But what's the other? When you undersample K-space, what's the penalty? Wraparound artifact, right? You get wrap artifact, right? So if you were just to do this, this is the picture you would get, okay? So here we're sampling all of K-space, Fourier transform that, you get this, everybody's happy. But what if you just scanned every other line, right? But you've reduced your imaging time by half, right? But the penalty you're going to pay is wrap artifact. You're going to get this, right? So The question is, how do we get rid of this? What can we do? This is the unfolding problem in parallel imaging. So if you're going to skip lines of K-space and do parallel imaging, you want to be able to take this image and unwrap it and then generate this image, right? So how do you do that? I mean, this works, we apply it. How does it work? Why does it work? So GE calls this asset. That's what the terms stand for, asset, right? So when you tell the technologist, we need to speed up the imaging sequence, use asset, right? What are they doing? This is what they're doing. They're skipping lines of K-space. But how do we unwrap it? It turns out that there are multiple coils that you're acquiring data from, right? There are coils on each side. The signal the anatomy that is closest to the coil will give you the highest signal. If I were to generate an image just from this coil, this is the image I would get, right? Because the anatomy that's as closest to the coil is going to give you your highest signal, right? That's why if you look at MR images, it's so bright right underneath the coil, okay? Because this anatomy is very close to the coil. The signal is going to be highest. That's what the image looks like. From the other side, if I were to generate an image from this coil, this is what it would look like. Again, because this anatomy over here is closest to this coil. That's what it looks like. It's by putting the data together that I'm able to give you this image, or you're able to generate this image that you look at, right? Well, there is some spatial information here, right? You can have what's called a coil sensitivity map. So this pixel out here is going to generate higher signal in this coil than it will in this coil. And that is a way of localizing it to this side of the anatomy instead of the other side of the anatomy to avoid the wrap. Okay? So by looking at each of these coils individually and the signal from this particular region of the anatomy, or where we want to map this signal, right? Do we want to map this on this side or this side? Well, we're going to map it on this side because the signal was higher in this coil than it was on the other coil. And so there is some spatial information there. And this is what the sequence uses, the software uses, to unwrap the image, okay? So it derives that localizing information by comparing the strength of the echoes in the different coils. So you're able to take this, right? Remember, if you didn't do this, you would get this wrap artifact. Well, if I have something here, how do I know to put it on this side or this side? Well, to look at it will decide, depending on the relative strength of the signal between the different coils. Okay, this belongs on this side. This belongs on this side. And then it can give you this. It unwraps the image, right? That's how it works. What are the penalties? Well, signal to noise reduces signal to noise by about 40%. So when you use asset, you will notice that your images are noisier, okay? The other thing is, if there is real phase wrap, you can't correct it. So you have to make sure that the field of view is larger than the object that you're scanning, right? Because it will not be able to correct if the anatomy falls outside of the field of view, it will not be able to account for that. Okay? So you have to make sure your field of view is large. So that's something that you have to bear in mind if you're going to tell the technologist to use asset to speed up your imaging. Okay? All right. So gradient echo imaging. That's what we used when we're doing bright blood imaging. So we talked about spin echo sequences for dark blood imaging. For bright blood imaging, we're going to use gradient echo imaging. So this provides good temporal resolution because we can do this, the TRs are going to be very short, very close together. Good for functional analysis. Demonstrates blood flow as bright, which is why it's called bright blood imaging. Regions of turbulence or very high velocity flow, like if you have stenosis or regurgitation, will be demonstrated as signal void, will be demonstrated as jets. So here in this left outflow tract view, what problem does this person have? What? So there is aortic stenosis, there is also what? Regurg. There's both aortic stenosis and regurgitation. So where you have turbulent flow, where you have stenosis and regurgitation, it will also show you these jets, which is advantageous, right? If we're doing function, if we're looking at the cardiac, and if we're looking at the heart, and we're also looking for function. So this is an ECG-gated gradient echo technique. You will see the word Cine applied to this. Cine flash, DIRFSE, yeah, these are all kind of synonymous terms for what you're doing. It's Cine, it's a movie, right? So how do we acquire this movie? Really, it's like any movie is acquired. You're putting together still images, still frames throughout the cardiac cycle, and then you're going to play them together. So we have a series of images at the same anatomic level at different phases of the cardiac cycle, and then we're going to string those images together in a movie. So it shows us wall motion, valve motion, blood flow, but realize that it looks like one heartbeat, but all of the information here was acquired over multiple heartbeats. And from that information, we're going to give you this, which looks like one heartbeat. Okay? So how is this done? Well, this is done through retrospective cardiac gating. The information is acquired rapidly and binned into phases. So basically, shoot first, ask questions later. So what you do here, or what is done, is that we're acquiring information very rapidly throughout the cardiac cycle at the same time as you have the ECG tracing here. And what the software will do is it will take all this information that is acquired and it will divide the cardiac cycle into phases. Here you have 8. We usually use 20. Right? It will divide it into phases, and any information that was acquired during this phase will be put in this bit. Whether it was from this heartbeat or the next heartbeat or the next heartbeat, it will put it in this bit. The same thing for the next phase and the next phase and the next phase. So there are multiple heartbeats that have been scanned. The information from each heartbeat is put in these selective bins. The images are reconstructed, so you have one image for each of these phases of the cardiac cycle, and then these images are put together and you have a movie of one heartbeat. Okay? So it looks like one heartbeat, but the information came from multiple heartbeats. And then this uses gradient echo imaging. We've talked about gradient echo, partial flip angle imaging. This does not require 180-degree pulses, which is why this can be done very rapidly, because you need a lot of information. You need to resolve every one of those images in each portion of that cardiac cycle. Okay? So for each image representing each phase of the cardiac cycle, you have to acquire all the lines of K-space. So if we have 256 pixels along the phase encoding axis, you have to acquire 256 lines of K-space for this one, this one, this one, this one, for each of these phases. Okay? So this is, how do we do this? This is called a segmented K-space acquisition. Multiple lines of K-space are obtained for each phase of the cardiac cycle during each heartbeat. So during this one single heartbeat, we will acquire multiple lines of K-space for this phase, same for this phase, for this phase, for this phase. So how many lines of K-space are you requiring at each phase, at each heartbeat? That is called the views per segment. So if we're going to acquire 4 lines of K-space here for this phase of the cardiac cycle during this heartbeat, and then we're going to acquire 4 different lines of K-space during the next heartbeat, our views per segment are 4. So the views per segment, the lines of K-space obtained at each phase of the cardiac cycle during each heartbeat. And remember, we have to get about 256 before we have enough to generate one image for each of these phases. Okay? So that's called a segmented K-space acquisition. temporal resolution, what does temporal resolution mean? Temporal resolution means how much time does that image represent? This image that you have reconstructed for this phase of the cardiac cycle, how much time does that really represent? And the temporal resolution is just this formula, the TR times the views per segment. That's how much time this image represents. So a lot of math here. Again, you're probably going to have to review this a little bit on your own. But if we're getting 12 views per segment, so if we're going to get 12 lines of K-space here, right, and we're going to need 192 overall before we have enough lines of K-space to generate an image, your TR is almost 4 milliseconds, which are very short TRs. So the temporal resolution here, how much time does that one image represent, is TR times the view per segment. In this case, it's almost 50 milliseconds, right? Now, since we are acquiring here 12 lines of K-space during each heartbeat, we're going to need 192 lines of K-space before we have enough to generate an image. We're going to need 16 heartbeats. And if the patient heartbeat is 60 beats per minute, that means it's a 16-second breath hold, okay? What's the point? Why am I going through this? Going through this because as the heart rate increases, this image will get blurrier and blurrier. And you need to correct for that. And how are you going to correct for that? You're going to correct for that by improving your temporal resolution, which means that you need to decrease the views per segment. That's what you will tell the technologist. So if your heart rate is 60 beats per minute, views per segment of 12 is okay. That's not going to give you blurry images. But if your heart rate is 122 beats per minute, right, then you may need to decrease your views per segment so that your images are not too blurry to improve your temporal resolution. Now, is there a penalty for that? Actually, no, because the heart rate has gone up, right? So in this case, it would take 16 heartbeats, which is 16 seconds. But if the heart rate was 122 beats per minute, and I reduced my views per segment to 6, I would need twice as many heartbeats. I would need 32 heartbeats. But the heart rate is faster. 32 heartbeats, if his heartbeat is 120 beats per minute, is still going to take 16 seconds. So I haven't really prolonged the breath hold, okay? But I've improved the temporal resolution and I've avoided blurry images. So that question might come up on exams, right? If the images are blurry, how do you improve your temporal resolution? When you're doing bright blood imaging, you need to decrease your views per segment to improve your temporal resolution. And what views per segment represents is how many lines of K-space are you acquiring at each heartbeat for each phase of the cardiac cycle, okay? Okay. I think what we'll do is we'll go on to the quiz.